Again, today we will talk about humeral shaft fractures. According to Zokerman review, which is a fast review about the important points in this fracture. First, the epidemiology. It is a common injury representing 3% to 5% of all fractures. The anatomy. The humeral shaft extends from the pectoralis major insertion to the supracondylar ridge. In this interval, the cross-sectional shape changes from cylindrical to narrow in the anteroposterior direction. The vascular sabri of the humeral diaphysis arise from perforating branches of the brachial artery, with the main nutrient artery entering the medial humerus distal to the midshaft. The musculotendinous attachment of the humerus result in characteristic fracture displacements. So you should see, according to this, concentrate with the teres major muscle, deltoid muscle, and brachialis and biceps. Okay. For fracture above the pectoralis major insertion, the proximal fragment will go for abduction and abducted, rotated externally by rotated cuff. The distal fragment will go medially and proximal by deltoid and pectoralis major. Between the pectoralis major and deltoid tuberosity, the proximal fragment will go medial by pectoralis, teres major, and latissimus dorsi. The distal fragment will go lateral and proximal by the deltoid muscle. In the fracture distal to the deltoid tuberosity, the proximal fragment will abducted by the deltoid, while the distal fragment will go medially and proximal by biceps and triceps muscle. The mechanism of injury. First, direct, which is the most common. Direct trauma to the arm from a blow or a motor vehicle accident result in transverse or comminuted fractures. And direct fall on outstretched arm result in spiral or oblique fractures, especially in elderly patients. Uncommonly, throwing injuries with extreme muscular contraction have been reported to cause humeral shaft fractures. Fracture patterns depend on the type of the force applied. For example, compressive, proximal or distal humerus fracture. For bending, transverse fracture of the humeral shaft. Torsional, spiral fracture of the humeral shaft. Torsional and bending will result in oblique fracture and often accompanied by butterfly fragments. What's the clinical evaluations? Patients with humeral shaft fracture typically present with pain, swelling, deformity, and shortening of the affected arm. A careful neurovascular examination is essential with particular attention to radial nerve. In case of extreme swelling, serial neurovascular examinations are indicated with possible measurement of compartment pressures. Physical examination frequently reveal gross instability with crepitus on gentle manipulation. Soft tissue abrasions and minor laceration must be differentiated from open fracture. Intra-arterial extensions of open fracture may be determined by intra-articular injection of saline distant from the wound side and noting extravasation of fluid from the wound. According to the radiographic evaluation, AB and lateral radiographs of the humerus should be obtained, including the shoulder and elbow joints on each view. So this view is not good because the shoulder, where is the shoulder here? Obtained view at 90 degrees from each other. The patient, not the arm, should be rotated as manipulation of the injured extremity will typically result in distal fragment rotation only. So don't go and rotate the arm of the patient, rotate the patient himself to make anteroposterior and lateral. It is very important to do anteroposterior and lateral with the shoulder and elbow in the fill. Traction radiographs may aid in fracture definition in case of severely displaced or comminuted fracture patterns. Radiograph of the contralateral humerus may aid in pro-operative planning. CT, body scan, and MRI rarely indicated except in cases in which pathological fracture is suspected. Classification here is descriptive. Open or closed, location, like proximal third, middle third, or distal third, according to degree, non-displaced or displaced, the direction and character, transverse, oblique, spiral, segmental, or comminuted, intrinsic condition of the bone, osteoporotic or not, and articular extension. The treatment. The goal is to establish union with an acceptable humeral alignment and to restore the patient to pre-injury level of function. Both patient and fracture characteristics, including patient age and functional level, presence of associated injuries, soft tissue status, and fracture patterns, need to be considered when selecting an appropriate treatment option. So, for these fractures and all fractures, the most important thing in any fracture for a doctor is to choose the best treatment for this patient, not for this fracture. We are not treating X-ray, we are treating patients. So you want to make all your effort to gather all informations about the patients, about the fracture, and then make a good decision. How will you treat this? Conserve or operative? If you choose conserve, what type of conserve and what's the plane of conserving treatment? If it's operative, what's the plan? So you are thinking about the patient and the fracture. What you think about is patient age, the functional level of him. Is he moving or no? If he's sports people or have a good musculature or no? A presence of associated injuries, if you have a nerve problem or no? Soft tissue status, if there is laceration or no? If there is burn, what's the fracture pattern you see, the X-ray, and all of this you should consider. First, an operative treatment. Requirements of non-operative treatment is understanding by the treating physician of the postural and the muscular force that must be controlled, dedication to close patient supervision and follow-up. The third, cooperative and perfectly upright and mobile patient, and an acceptable reduction. Most humerus shaft, more than 90%, will heal with non-surgical management. 20 degree of anterior angulation, 30 degree of varus angulation, and up to 3 cm of pionate apposition are acceptable and will not compromise the function and appearance. Hanging cast, this is the first option. This utilizes dependency. Okay, let's go first to think about the fracture who is to be treated with conservative measures. We said that first, it's simple fracture, no segmented, not go intra-articular, it's just simple fracture. Now you should examine the angulation and the shortening. For this one, try to make your lines. Yes, here it's varus for 15 degrees and less than 3 centimeters. This is very nice to be treated non-operative. For this fracture, after making the lines, the degree of varus and the degree of anterior and or posterior, this one going valgus and posterior, valgus with 20 degree and posterior with 30 degree, and there is less than 1 centimeter. I think it can be good with conservative measure, but with some traction. First option of the conservative management is the hanging cast. This utilizes dependency traction by the weight of the cast and the arm to affect fracture reduction. Indications include displaced mid-shaft humeral fracture with shortening, particularly spiral or oblique pattern. Transverse or short oblique fractures represent relative contraindication because of the potential for distraction and healing complication. The patient must remain upright or semi-upright at all the time with the cast independent position for effectiveness. It's frequently exchanged for functional bracing 1 to 2 weeks after injury, and the union rate here is more than 95. Second choice is a cohabitation splint. This utilizes dependency traction to affect the fracture reduction, but with greater stabilization and less distraction than a hanging arm cast. The forearm is suspended in a collar and cuff. It is indicated for the acute treatment of humeral shaft fractures with minimal shortening and for short oblique or transverse fracture pattern that may displace with a hanging arm cast. So for that short oblique or transverse, you will use this one. Disadvantage here include irritation of the patient axilla and the potential for splint slippage. It is frequently exchanged for functional braces 1 to 2 weeks after injury. Third option is the thoracobrachial immobilization, veil bow dressing. This is used in elderly patients or children who are unable to tolerate other methods of treatment and in whom comfort is the primary concern. It is indicated for minimally displaced or non-displaced fracture that does not require reduction. Passive shoulder bend-over exercise may be performed within 1 to 2 weeks after injury. It may be exchanged for functional bracing 1 to 2 weeks after injury. Third option is shoulder spica cast, which is historical. This has limited application because operative management is typically performed for this same indication. It is indicated when the fracture pattern necessitates significant abduction and external rotation of the upper extremity. The disadvantages include difficulty of cast application, cast weight and bulkiness, skin irritation, patient discomfort, and inoculating for upper extremity position. What's the functional bracing is this one, which is the choice after you choose the first one. This is second one. It is typically applied 1 to 2 weeks after injury. After the patient has been placed in a hanging arm cast or cohabitation splint and swelling has subsided, it consists of an anterior and posterior shell held together with a Velcro strap. Success depends on the upright patient and brace tightening daily. Contraindications include massive soft tissue injury, unreliable patient, and inability to obtain or maintain acceptable fracture reduction. Collar and cuff may be used to support the forearm, but sling application may result in varus angulation. The functional brace is worn for a minimum of 8 weeks after fracture or until radiographic evidence of union. Let's talk about the operative treatment. What's the indication for operative treatment? First, multiple trauma, inadequate close reduction or unacceptable malunion, pathological fracture like this one, associated vascular injury, floating elbow like this one, segmental fracture, intra-articular extension, bilateral humeral fracture, open fracture, neurological loss following penetrating trauma, radial nerve palsy after fracture manipulation, and this one, non-union. The surgical approach to the humeral shaft includes anterolateral approach, which is preferred for proximal third humeral shaft fracture, radial nerve identified in the interval between the brachial and brachioradialis, and traced proximally. This can be extended proximal to the shoulder or distally to the elbow. Anterior approach is the muscular interval between the biceps and brachialis muscles. Posterior approach provides excellent exposure to most of the humerus, but cannot be extended proximally to the shoulder. Muscular interval between the lateral and long heads of the triceps are used. Surgical technique, open reduction and blade fixation. This is associated with the best functional result, the blades. It allows direct fracture reduction and stable fixation of the humeral shaft without violation of the rotator cuff. Radiograph of the uninjured contralateral humerus may be used for preoperative planning. A 4.5 mm dynamic compression blade, which is the mini compression blades, with fixation of 8 to 10 cortex proximal and distal to the fracture is used. Leg screws should be utilized whenever possible and should preserve soft tissue attachment to butterfly fragments. Okay, here we want to talk for comparison between the minimal invasive blades, the MIBO blades, and this plate. The operation was carried out, this is the paper. The operation was carried out in a supine position with abduction of the injured arm under image intensifier control, preserving, if possible, the cephalic vein. The proximal humeral shaft was exposed through the deltobicipital interval. This is the deltobicipital interval. A distal incision of 4 to 5 cm was performed on the anterior side of proximal to the elbow crease. The sensory branch of the musculocutaneous nerve was usually identified and protected after retracting the biceps muscle. This is the musculocutaneous nerve. The brachialis muscle was split by blunt dissection. A submuscular tunnel was then developed using the blade and the locking sleeve as a handle. Under image intensifier control, reduction was achieved by manual traction, and an additional external fixator was used to maintain the reduction. depending on its difficulty in reduction maneuver. Okay, 9 to 12 hole plate was used for fracture stabilization. The plate was fixed on the anterior surface of the humerus. Generally, 3 bicortical screws, either locking or cortical, were inserted on both sides of the fracture, but 2 screws were fixed in 2 distal shaft fractures. Radial nerve exploration was not undertaken here. And this is the final shape of the Mebo plates. We'll find 2 or 3 in every cortex, and you make only 2 small incisions, 4 or 5, 1 high and 1 low. Okay, now the intramedullary fixation. Indication of intramedullary fixation: segmental fracture in which plate placement would require considerable soft tissue dissection. Humerus fracture in extremely osteoporotic bone, or pathological humerus fracture. It is associated with a high incidence of shoulder pain following antegrade humeral kneeling, so the most common and most serious complication of intramedullary fixation is the shoulder pain during impingement. 2 types of intramedullary nails are available for use. I will talk about flexible nails, and this is historical also. The interlock nail. This nail have proximal and distal interlocking capability and are able to provide rotational and axial fracture stability. With antegrade kneeling, the axillary nerve is at risk of injury during proximal locking screw insertion. Screw protruding beyond the medial cortex may potentially impinge on the axillary nerve during internal rotation. Anterior to posterior screws are avoided because of the potential for injury of the main trunk of the axillary nerve. So for the proximal, AB screws are avoided. Distal locking usually consists of a single screw in the anteroposterior plane. Distal locking screw can be inserted anterior to posterior or posterior to anterior by an open technique to minimize the risk of neurovascular injury. Lateral to medial screw risked injury to the lateral antebrachial cutaneous nerve. Either type of nail can be inserted through antegrade or retrograde technique. Why people think about retrograde technique? Because of the pain in the shoulder. If antegrade technique is elected, most methods attempt to avoid the rotator cuff to minimize the post-operative shoulder problem. The proximal aspect of the nail should be countersunk to prevent subacromial impingement. For subacromial impingement, first they try to do retrograde nail, and second they try to make it sunk away from the subacromial space. Last thing is the external fixation. It have its own indication, which are infected non-unions, burn patient with fractures, open fracture with extensive soft tissue loss. Complications include pen tract infection, neurovascular injury, and non-union. Post-operative rehabilitation. Range of motion exercise for the hand rest should be started immediately after surgery. Shoulder and elbow range of motion should be instituted as pain subsides. Okay. Complications. Radial nerve injury. It's occur in up to 18% of cases. It is the most common with middle third fracture, although best known for its association with Holstein-Lewis type 3 distal third fracture, which may entrap or lacerate the nerve as it passes through the intramuscular septum. Most injuries are neuropraxia or axonotmesis. Function will return within 3 to 4 months. Laceration is more common in open fracture or gunshot injuries with secondary pulses that occur during fracture reduction. It has not been clearly established that surgery will improve the ultimate recovery rate compared with non-surgical management. Delayed surgical exploration should be done after 3 to 4 months if there is no evidence of recovery by electromyography or nerve conduction velocity study. Advantage of late over early nerve exploration are enough time will have passed for recovery from neuropraxia or neurotomesis. Second, precise evaluation of nerve lesion is possible. Third, the associated fracture may have united. The result of secondary nerve repair as good dose of primary bear. So for radial nerve injury, there is no indication to do the surgery. Wait 3-4 months to 4 months. Vascular injury, this is uncommon but may be associated with fracture of the humeral shaft, laceration, or impaling the brachial artery, or with penetrating trauma. The brachial artery has the greatest risk for injury in the proximal and distal third of the arm. Third complication is non-union, occur in up to 15% of cases. The risk factors include fracture at the proximal or distal third of the humerus, transverse fracture pattern, fracture distraction, soft tissue interposition, and inadequate immobilization. It may be necessitate open reduction and internal fixation with bone grafting. And last thing is the malunion. This may be functionally arm musculature, shoulder, elbow, and trunk range of motion can compensate for angular, rotational, and shouldering deformities. And this is the end according to Zokerman. It is very small review about the fracture, and also the most important thing, how to choose the best method to treat your patient, and think about all complication. Conservative, give 90%, but only for segmental. Try to minimize the use of operative treatment for shaft fracture, except if indicated when open fracture or something like segmental, intra-articular, or something like this. But for just simple fracture, try to use your methods of conservative methods and treat this patient with close follow-up for him, weekly or less than. And also it's very important to try to move as early as possible, because stiffness in shoulder is one of the most common places to have to come early if you don't move for 2 weeks or something. Don't